We are from SGD before. We are going to discuss about compartment syndrome, and this is our member. Okay, next, and this is the background why we choose compartment syndrome. Okay, compartment syndrome is a serious problem in musculoskeletal system, and the misdiagnosed or the delayed diagnosis could lead into amputation or even death. So that we as the student, we need to learn more about the compartment syndrome. Next will be discussed by my friend.
Okay, now I'm going to explain about the definition of the compartment syndrome. Compartment syndrome is a condition in which the compartment pressure increases due to muscle hypertrophy, increased fluids, and compromised drainage of the area. There are two types of compartment syndrome, acute or chronic. Acute compartment syndrome is usually caused by trauma such as fractures, crush injuries, muscle rupture, direct blow to a muscle, and circumferential burns. And unlike the acute version, the chronic compartment syndrome is usually caused by exercise and strenuous activity. The next is going to be explained by my colleague.
Here are the etiology of compartment syndrome. The muscle expansion, which is caused by repeated exercise, will increase pressure within the fascial compartment. This will result as compartment syndrome. Birth trauma and low perfusion of the extremities in neonatal, individuals who genetically have high muscle tone, or even snake and insect bites can also cause this syndrome. In children, this syndrome is usually caused by trauma. For example, femur fractures, supracondylar, humerus fractures, and forearm fractures. There are few risk factors. The first one is open fractures, and then high energy trauma, concurrent humerus and forearm fractures, and last one is male gender. Thank you.
My name is Samantha and I'm going to explain about the epidemiology of compartment syndrome. The first one is chronic compartment syndrome. It has very unclear or uncertain number of prevalence because there are very small amount of study that learn about this. But one of the studies stated that only 7.6% of general population might have chronic compartment syndrome. The next one is acute compartment syndrome. Next, the acute compartment syndrome actually have a very clear epidemiology, especially the most common studied site for acute compartment syndrome, which is the anterior distal of lower extremities. The most precipitating event for acute compartment syndrome is tibia fracture, which involve in 1 to 10% of acute compartment syndrome cases. Acute compartment syndrome happens more to male than female, with estimation of 7.3 per 100,000 in males and 0.7 per 100,000 in female. Acute compartment syndrome happens most likely to male with age under 35 because probably due to the high chance of involved in high trauma incidents. Thank you.
Hello, my name is Laras and my number is 104, so I will tell you about the pathology. So, compartment syndrome occurs when intra-compartment fluid volume increase or intra-compartment space decrease and causes hemodynamic impaired. Thus, this incident caused an increase in compartmental pressure, and the venous capillary also began to increase and decrease. Arterial inflow will also occur because the intracompartmental pressure becomes higher than arterial pressure. This reduction of arterial inflow and venous outflow results in decreased oxygenation of tissues and causing hypoxia and the ischemia. And the next will be explained by my friend. Thank you.
The symptoms of compartment syndrome classically can be classified into 5 Ps. Those are pain, pallor, pulselessness, paralysis, and paresthesia. And the earliest indicators of acute compartment syndrome, or ACS, are pain out of proportion to the injury and pain with a passive stretching of the muscles and the compartment. And clinical investigations play an important role in diagnosis of ACS, such as compartment pressure monitoring, intramuscular or IM partial pressure of oxygen, near-infrared spectroscopy or NIRS, and also serum biomarkers, etc. And chronic exertional compartment syndrome or CECS may occur in individuals who participating in sports, but most often in running athletes. And the typical presentations of CECS is recurrent anterior, posterior, or lateral leg pain with repetitive physical activity, and symptoms will be relieved by rest. And the CSS patients usually feel tight cramping, pressure, or pain sensation in a specific location or compartment. And paresthesia, transient foot drop, and also numbness are neurological symptoms that associated with CSS. And post-exercise needle manometry is suggested in confirming the diagnosis if the symptoms are consistent with CECS.
So I will explain about the differential diagnosis of compartment syndrome. There are several signs and symptoms of compartment syndrome that can lead to a misdiagnosis. The first one is deep vein thrombosis or DVT. It's a subset of venous thromboembolism where it shows major signs and symptoms like asymmetrical swelling, warmth or pain in an extremity. The next one is cellulitis. It is an acute infection of the skin that involves dermis and subcutaneous tissues, where the clinical presentation of cellulitis includes redness, pain, swelling, and warmth. The next one is gas gangrene or myonecrosis. It's a highly lethal infection of the soft tissue caused by Clostridium species. It shows signs of infections such as fever, chills, pain, and less superficial inflammation at the site of infection than one would expect given the deep penetrating nature of these infections. The fourth one is Plekmachia cerulidolens or PCD. It's a complication of acute DVT, and it is uncommon to see PCD, but it can potentially threaten patient's life. PCD is characterized by marked swelling of the extremities, accompanied with pain and cyanosis. The last one is peripheral vascular injuries. Trauma to the vascular system itself can come in three forms. There are blunt, penetrating, or a combination, where these injuries usually occur in civilian or military setting. The mechanism of injury is important to determine the form.
I want to explain about the management of compartment syndrome. Compartment syndrome management includes removing the dressing, administering analgesic, placing the limb over the heart, resuscitation, fasciotomy, and hyperbaric oxygen. I want to explain one by one. First, remove the constrictive dressing. It can reduce the chance of developing this syndrome. Second, we can do Trendelenburg position. This position is placing the limb over the heart. It is important to decrease the associated edema. Third, we can give analgesic to reduce patient's pain. And the next, we can do resuscitation and restoring of circulating volume. It is intended for hypotension patient to restore perfusion pressure. We can do surgical. It's called fasciotomy. Indications for performing fasciotomy are based on intracompartment pressure and differential pressure. The last, hyperbaric oxygen. It is an adjunctive treatment. It can be used for promoting hyperoxic vasoconstriction, reduce edema, and improve tissue oxygen.
Complications. A late diagnosis can show absence of a distal pulse, hypoesthesia, loss of sensation in the body part, and extremity paralysis, weakness of voluntary movement, because the elevating tissue pressure compromises arterial blood flow. Painful dysesthesia may also be felt by the patient, but these conditions can resolve slowly, and phenytoin, gabapentin, or carbamazepine are considered to make the patient more comfortable. With no adequate treatment, the muscles and nerve within the compartment undergo ischemic necrosis, resulting in a Volkmann contracture, which shows a permanent flexion position at the wrist and fingers, and shows a claw-like deformity of the hand. This happens due to permanent shortening of the flexor group muscles in the forearm, hence resulting in pain on passive flexion. And then peroneal nerve palsy, a common entrapment neuropathy of lower extremities that might also occur, which is generally presented with weakness of ankle dorsiflexion and foot drop, which is inability to hold the foot straight across, as well as the patient may drag their toes while ambulating. After that, lower extremity compartment syndrome can also cause rhabdomyolysis, which is characterized by necrosis of muscles and the release of intracellular muscle constituents into the circulation, typically shown by elevated creatine kinase levels, muscle pain, as well as myoglobinuria. Moreover, severe cases may also lead to kidney failure and also death.
In compartment syndrome, there's no definite way to prevent it, but based on several studies, early detection can help prevent compartment syndrome from getting worse. For instance, intra-abdominal pressure measurement has a role in prevention in early diagnosis of abdominal compartment syndromes. Early diagnosis and decisions for decompression treatment can save life. Fasciotomy can be done to treat compartment syndrome so the permanent disabilities can be prevented. Side effects of compartment syndrome can be prevented by fasciotomy from qualified emergency physicians or orthopedic surgeons. Things like death or amputation are less occurs. Even other side effects such as weakness of limbs, foot drop, and deficit of sensory in area sometimes reported.
Okay, the next is the prognosis. Studies show that acute compartment syndrome has mortality rate up to 47% due to complication like infection, which ultimately led to sepsis and multi-organ failure. Almost all prognosis value of this disease are dependent on time and how quickly the condition is diagnosed and treated. Also, subsequent operative procedures such as fasciotomy is also involved. In patients with the late diagnosis, amputation is commonly done to increase the chance of survival of the patient. We also found that the current compartment syndrome has to be known to occur in the athlete due to scarring.
My name is Gribranu Nugradena. In conclusion, compartment syndrome as a problem needs to be diagnosed accurately and as soon as possible before it leads to a more serious effect such as necrosis, paralysis, kidney failure, and even death. Some of the tests to diagnose compartment syndrome is by imaging such as radiograph and MRI, with EMG could be used if neurologic symptom is present. And the treatment for this syndrome is by removing constrictive dressing, doing the Trendelenburg position, and using analgesic to reduce the pain. Thank you.